Okay, Bismillah ar-Rahman ar-Rahim. Thank you, first of all, thank you to the organizing committee for giving me this opportunity. And thank you for the Pediatric Association. And thank you, my colleague Muhammad Al-Hassan. Inshallah, I will try to be simple. And it is a big topic to have one lecture for acyanotic congenital heart disease and the acquired heart disease. It's very big topic. But we will start.
لحظة يا دكتور بشير، سوري، في كومنت هنا بيقول إنه الظهور هيأذن في السودان بعد دقيقتين. هل فعلا هيأذن بعد دقيقتين؟
لا لسه.
في واحد كاتب إنه ناخذ البريك عشان الظهور باقي دقيقتين في السودان.
لأنه لسه ما أذن والله. هو بيأذن عندي هنا تقريبا بعد 8 دقائق كده.
طيب اوكي، اللكشر بتاعتك حوالي كم؟
والله ان شاء الله ما اكثر من ساعه.
طيب اوكي خلاص، جو اهيد سوري.
طيب first of all we have to start with the normal heart and we have to know the fetal circulation. In the fetal circulation we have the placenta from which the blood is going to the fetus. The oxygenated blood will go through the umbilical vein, and the umbilical vein through the ductus venosus or the venous duct, the inferior vena cava, going to the right atrium, and through the foramen ovale, it will go to the left heart, left side, the left atrium. So the well-oxygenated blood will go to the left atrium, and then through the mitral valve to the left ventricle, and then it will go to the aorta, to supply the upper part of the body, the neck vessel, and then we'll go to the descending aorta. So we have this ductus venosus, and we have this one called ductus arteriosus. So ductus arteriosus is a fetal structure. When the child born, this ductus arteriosus will close. If it persists, it will be called patent ductus arteriosus. And we have to know the anatomy of the normal heart. We have two circulation, pulmonary circulation and systemic circulation. There should be no shunt, no atrial shunt, no ventricular shunt. The PDA should be closed. And the valve should be okay, and the great vessel, there should be no nerve. Childhood cardiovascular disease classified as congenital or acquired. Acquired will be our second lecture. The congenital, either cyanotic or acyanotic. Cyanotic, Dr. Hussein will talk to them. But all of us, we know the 5 T's: TOF, truncus, TGAT, BVD, tricuspid atresia, and the hypoplastic left heart, Epstein anomaly, and pulmonary atresia. The acyanotic, this is our topic today. We'll talk about the VSD, ventricular septal defect, atrial septal defect, patent ductus arteriosus, the obstructive lesion like pulmonary stenosis, aortic stenosis, AVSD, atrioventricular septal defect, coarctation of the aorta, and interrupted aortic arch, and PS and AS. Other classification: cyanotic, acyanotic. This is the congenital heart disease. Cyanotic to acyanotic. The acyanotic, either acyanotic with increased pulmonary blood flow due to septal defect like ASD, VSD, BDA, and AVSD, or obstruction to the blood flow from the ventricle, or obstructive lesion like coarctation of the aorta, aortic stenosis, and pulmonary stenosis. The incidence of congenital heart disease approximately 1 in 120 live births, يعني 0.8%, or you can say 1%. The cyanotic only 22%. Most lesions are acyanotic, 68%. Like the VSD is the commonest, 25 to 35, ASD 6%, PDA 6%, coarc 6%. And TOF, there is pink TOF or acyanotic TOF, only 5%, PS 5%, AS 5%, and AVSD 3%. The etiology of congenital heart disease mostly unknown, or you can say it is multifactorial, either environmental or sometimes associated with chromosomal abnormalities or other genetic disorder. The most common is trisomy 21, Down syndrome, and 50% of them are associated with AVSD, atrioventricular septal defect. And trisomy 18 or Edward, associated with septal defect, most likely VSD, trisomy 13 or Batau, associated with BDA, VSD, and ASD. DiGeorge syndrome, this one associated with conotruncal abnormalities or arch anomaly, like interrupted aortic arch. Also, Turner syndrome, associated with coarctation of the aorta. 20% of Turner, they have coarc. Williams syndrome, associated with supraortic stenosis, pulmonary artery stenosis. Noonan syndrome, associated with Hookham, or also associated with dysplastic pulmonary valve. First of all, for you as a pediatrician, if you suspect any congenital heart disease, you have to go sequentially. You will ask about symptoms. The most important thing is feeding. Any difficult feeding, any sweating with feeding, any cyanosis, any failure to thrive. And murmur is the most common presentation for congenital heart disease. And cyanosis, you have to check it, not the peripheral cyanosis, not around the lips and the fingers, inside the mouth and the tongue. And you have to check it with the pulse oximeter. You have to verify it with the pulse oximeter, the patient, to confirm the patient has cyanosis. And if neonate, you have to do a hyperoxia test, give him 100% oxygen for 10 minutes to make sure is it lung problem or non-cardiac or cardiac. And the symptom and sign mostly presenting with heart failure, either left-sided heart failure symptoms or right-sided heart failure symptoms. Then we will go to the types of acyanotic congenital heart disease. First of all, we start with the ASD, atrial septal defect. That means there is a defect inside the atrial septum. Isolated atrial septal defects, about 5 to 7% or about 6% of congenital heart disease. Majority of cases are sporadic without known cause, or some of them are associated with Holt or Ram syndrome. Holt or Ram syndrome, either absent thumb or absent radii. They're the most common disease associated with atrial septal defect. Type of ASD, either ASD secundum. ASD secundum, that means at the site of the foramen ovale, in center or inside the center of the atrial septum, called ASD secundum. Actually, in the septum primum. And ASD primum, this is the one in the lower part of the septum, due to the absence of the endocardial cushion. And this is the one associated with Down syndrome, ASD primum. The third one is sinus venosus ASD. Sinus venosus is the one at the mouth of the superior vena cava or at the mouth of the inferior vena cava. This one, superior sinus venosus, and this one, inferior sinus venosus. ASD is a simple lesion. The child will not be symptomatic in the childhood, even if he has a large ASD. And also the types either small, according to the size, small, moderate, large. And even the large one, which is more than 8 to 10 millimeter, we will not interfere unless the child is more than 4 years, because during the first 4 years of life, the child has a susceptibility to close. The ASD has susceptibility to close. Most of them will close during the first 4 years of life. If it's still present after the 4th year of life, then it needs to be closed. And if ASD secundum, if the child more than 4 years and the weight more than 15 kg, most likely it will be closed by device. Will be closed by a device. So that's why we are waiting. We are waiting after 4 years because it may become small, or it may close, or if not close, the child will has a good weight for catheter intervention. The ASD primum and the sinus venosus, this one will be closed by surgery. If the ASD is very huge, sometimes even if it is secondum, it needs to be closed by surgery. The second acyanotic congenital heart disease, VSD, as we said, it is the commonest form. It is the most common form of congenital heart disease, about up to 35% of congenital heart disease, and divided into perimembranous, which is the commonest form. Perimembranous, that means in the membranous area, which is under the aortic valve, and it constitutes up to 70% of all VSD. It is called perimembranous because the membranous septum is very small. It is in the membrane and around the membrane in the muscular part. Second one is the muscular VSD in the muscular part of the ventricular septum. The ventricular septum, muscular, or this one, membranous. And the muscular form 30% of all VSDs. There is a rare type of VSD called inlet VSD, just below the tricuspid valve and the mitral valve. It is called inlet. This one associated with Down syndrome, and sometimes associated with AVSD, part of the AVSD. Trabecular, this is the muscular, either anterior or posterior. And the last one is the outlet VSD. Outlet, that means near the outlet of the ventricle, near the pulmonary valve or the aortic valve, or below both of them. This is called outlet VSD. VSD also either small, moderate, or large. Regarding the muscular VSDs, if it is small, most likely to close by itself. If it is large and not closed, after follow-up, it may need closure by device in the muscular. But the inlet type and the perimembranous type, most likely they will be closed by surgery. And VSD is more dangerous than the ASD. The ASD, we said we can wait, but the VSD, the child can present even after 6 weeks of life. When the pulmonary pressure drop, the left side pressure will be very high and the pulmonary pressure drop, so they will be left to right shunt, and there will be more blood to the right ventricle and to the pulmonary arteries, and the lung will be flooded by huge volume of blood, so the child will be tachypneic and will be in heart failure. If a small child, we can start him on anti-failure medication like diuretics, Lasix, aldactone, or we can start him also on ACE inhibitor like captopril. The PDA, as we said, ductus arteriosus is an important structure of the fetal circulation. It should be present in all fetal in all fetuses. If it's closed prematurely, intrauterally, they will be right heart failure and even IUFD. But after birth, the ductus arteriosus mostly closed by the second or third day of life. 50% will close by the end of the first day, and 75% by the second day, and 90% by the third day of life. But if persist, it will be called patent ductus arteriosus. It is very most common in premature babies, because the premature babies still they are not mature enough, so the ductus arteriosus will be open, and sometimes it will cause a respiratory distress syndrome, and the child will be unable to wean from the ventilator in the preterm. And sometimes even if it is large, it needs to be closed in the neonatal period. If in the neonatal period, the only mode of closure is surgical. Because the child is tiny, they cannot introduce a device in small neonate. Sometimes seen in other congenital heart disease like rubella syndrome. Part of the rubella syndrome is the patent ductus arteriosus. If it is small and the child old, more than 1 year of age, if it's causing hemodynamic effect by left side dilatation, the child is failing to thrive, it needs to be closed. And most likely it will be closed by a device. It will be closed by a catheter, transcatheter closure by the device. Sometimes this PDA, we need it because of some complex congenital heart disease. They are duct dependent. After the neonatal period, before doing surgery, we need the PDA to be patent in some complex cyanotic congenital heart disease. And even we are giving prostaglandin to keep the PDA patent or open, especially in hypoplastic left heart syndrome, in tricuspid atresia.
Bashir, we are not hearing your voice. Are you still there?
Yeah.
Bashir, we are not hearing.
The PDA to left side lesion like the aorta or interrupted aortic arch, and the child, if the prostaglandin is not given, if the prostaglandin is not given, the child will present by with a shock like sepsis and like sepsis and like metabolic disorder. So metabolic disorder and sepsis are differential of obstructive left side cardiac lesion. AVSD, atrioventricular septal defect. What is it? This one, there is an ASD primum, there is an inlet VSD, and there is a common AV valve. So all the center of the heart or the crux of the heart is defective or absent. So they will be a mixing between the left side and right side. It is involved with defect of the embryonic endocardial cushion tissue. Incidence about 3 to 4% of all congenital heart disease, but it is very common in Down syndrome. 50% of Down syndrome has AVSD, and 50% of
Bashir, there is
your
interruption in the voice.
The AVSDs are Down syndrome babies. Complete like this one, SD primum in the D. SD primum, في interruption? Sorry?
Yes. مرتين كده الصوت راح
كده واضح؟
واضح ايوه.
اوكي. قلنا بالنسبة لل AVSD يا جماعة either complete like this one or incomplete. Incomplete, there is no VSD. It is only ASD primum, and the AV valve, the AV valve is defective. As we said, 50% of Down syndrome has AVSD, and 50% of the AVSDs are Down syndrome babies. This one need to be treated by surgery, the complete AVSD, in the first 6 months of life. And before that, before surgery, we can give the patient anti-failure medication because he will present with heart failure. Then we will go to the obstructive lesion, either obstructive to the right side of the heart or to the left side of the heart. Obstructive lesion of the left side of the heart, we will start with aortic stenosis. It can be very severe or critical and can present with shock due to low cardiac output, because this is the only outlet to the systemic circulation. And in this case, it needs a prostaglandin to keep the PDA open. We will give the prostaglandin to keep the PDA open, and the management after stabilization of the patient by transcatheter balloon dilatation. And most of children will respond to balloon dilatation. If not, they will go for surgery. Pulmonary stenosis also, this is obstructive side pulmonary, severe or critical, mild or moderate. It can present, if it is severe, it will be presented by cyanosis due to minimal blood flow going to the lungs. Here, minimal blood flow going to the lung to be oxygenated. And in this case, need to be given prostaglandin to keep the PDA open. And after that, the management by balloon dilatation, transcatheter balloon dilatation. But if it is mild, it needs to be followed up. And most likely, if it is mild, no need for any intervention, only follow-up. One of the obstructive cardiac region is aortic coarctation or coarctation of the aorta. What do we mean by coarctation of the aorta? Narrowing of the aortic arch just below the subclavian artery in the isthmus area, this one, and lead to obstruction of blood flow to the lower part of the body. It can be discrete, like this one, or it can be diffuse. Diffuse, that means long segment associated with arch hypoplasia. And the one discrete, it can be mild, moderate, or severe. And the severe one, it can be to the extent there is interruption of the aortic arch. Incidence about 5 to 7% of all congenital heart disease associated with Turner syndrome in female, as we said. Aortic arch interruption associated with DiGeorge syndrome. And if not treated, it can lead to systemic collateral to bypass aortic coarctation. There will be a collateral from the subclavian to the descending aorta. If it is severe, in the first 3 months of life, it needs surgery, arch repair or coarc repair. If it is mild, it can be followed till adult life. After that, it may need balloon dilatation or even stent placement to prevent recoil of the arch. As we said, interrupted aortic coarc, severe coarc, it can be extended to interruption of the aortic arch, like this one. This one, interrupted aortic arch type A, there is complete interruption between the isthmus and the descending aorta, and the PDA should be patent to supply the lower part of the body. This is interrupted aortic arch type B between the left common carotid and left subclavian, and this is interrupted aortic arch type A. Only the innominate, the first branch going to the neck, is the one from the ascending aorta. And interrupted aortic arch, this duct-dependent lesion. If you are a pediatrician in the periphery, you have to give prostaglandin before transferring the patient to a cardiac center because the only method of treatment is arch repair surgery. Also, same presentation, same like co-arc. If the BDA closed, the patient may present with shock-like due to low cardiac output, severe metabolic acidosis, and also you have to put in mind it is a differential of sepsis and metabolic. Regarding the acyanotic congenital heart disease for diagnosis, first you have to have a good history. Ask about is he preterm? If preterm, most likely BDA, dysmorphic or not dysmorphic, because each syndrome has associated lesion. Feeding, interrupted feeding or difficult feeding associated with sweating, failure to thrive, oxygen saturation, physical examination. Also, you have to have full examination starting from the pulse, the femoral pulses, especially in unit. You have to feel the femoral pulse, and you have to have forelimb blood pressure. Dr. Hussein, inshallah, will talk to you about screening for cyanotic congenital heart disease. And you have to have listen to if there is any murmur. After that, you have to do chest X-ray, ECG, and after that, you can send to a cardiologist for echo, CAS, CT, and MRI, and refer to pediatric cardiology if you suspect any congenital heart disease. And sometimes this referral should be urgent, especially in unit with murmur or cyanosis or suspected severe obstruction or the patient in heart failure. Regarding the investigation, our tool as a general pediatrician is the chest X-ray. Chest X-ray is mandatory for any patient suspected as congenital heart disease. And in this one, you have to see, sometimes you will find if this is a stomach papil, and this is a liver on the right side, this is visceral situs solitus. And then you have to see the orientation of the apex, levocardia or dextrocardia. And then you have to comment on the heart size. Is there any cardiomegaly or not? You have to measure the heart. You will drop a midline and then see the biggest one on the right and the biggest one on the left. And to see the heart widths and compare it with the thoracic, cardio-thoracic ratio. If more than 50% in children or more than 60% in unit, this is cardiomegaly, like this one. And you have to see the lungs. Is the child oligemic or bilosolic? This one is bilosolic. How to know it is bilosolic? See, this is a descending pulmonary branch, right pulmonary branch. If you compare it with the trachea, it is congested, congested. So this child has cardiomegaly and congested lungs. This one has dextrocardia. And also you have to see the mediastinum, narrow mediastinum or normal mediastinum, because the child has thymus. This one, even we can see narrow mediastinum and the heart like a boot shape. Boot-shaped heart, like the one in tetralogy of Fallot or pulmonary atresia. This one also there is narrow mediastinum, and the heart, it looks like an egg on a string. This one common in DTGA. Dr. Hussein, inshallah, will show you. This one is snowman, like a snowman in KBVD, also in the cyanotic congenital heart disease. This one is not an regular X-ray. This is an X-ray, but there is a aortogram injection inside the descending aorta. It shows you there is co-arc. if there is no injection, sometimes if you are lucky, you will see a figure of 3. But in older children. ECG, Dr. Wafa, she talked all about this, rate, res, B, and QRS axis, interval, chamber hypertrophy, and ST, and T wave changes. If you will refer to pediatric cardiology service, they will do an echo. Sometimes they will send the child to the cath lab, or even they will go to the advanced cardiac imaging, like a CT or cardiac MRI. Because in complex congenital disease, sometimes you need more elaboration, especially in the extracardiac structure. Echo is the gold standard in congenital heart disease diagnosis. When you will refer to pediatric cardiologist and we do echo, you will find what is the lesion, like this one. This is a BSD, and area showing the left side is dilated. Therapeutic option, first of all, we have to augment nutrition because most of them, they have failure to thrive. And also you can start a pharmacological therapy like diuretics and anti-failure medication like ACE inhibitor. If the child has arrhythmia, you will start anti-arrhythmia. Sometimes you will give specific medication like beta blocker. And if the child has infection, treat infection because infection will aggravate the heart failure and the cardiac symptoms. If the child needs catheter-based intervention, you can, the cardiologist will do it. Like this one, this is ASD closure. This is an ASD device. There are 2 discs, one disc here and the other disc here. They will be like a button closing the atrial septal defect. Or this child has a pulmonary stenosis. The interventionist will put a balloon inside the pulmonary valve and will inflate the balloon so it will be treatable. Balloon dilatation, like in aortic stenosis, pulmonary stenosis, and coarctation if you're old enough. And sometimes they are doing other intervention like cystectomy. Proper timing for surgery, each lesion has a proper time for surgery.
Sorry, Dr. Bashir, sorry. There is many raise hand. I guess these people has question. Please, again, type your question in the question box. We are there to answer your question. Please type all your questions in the question box. Bashir, you carry on. All that and these, please, if you have question, write it in the question box.
Okay.
Thank you. Continue, Bashir. Thank you.
Regarding the therapeutic procedure, either cath or surgery, they are either palliative or curative. Curative, that means the child will be cured and no more intervention. Sometimes only palliation. Palliation, that means ameliorating the disease and make it less disastrous. We finish the first part. Then we will move to the second part, is the acquired heart disease in children. As we know, all the acquired diseases, either ischemic or hypoxic, inflammatory, rheumatic, hypertensive, metabolic, arrhythmogenic, infectious, nutritional, or others. Infection related, like infective endocarditis. We have the infective endocarditis, which is mean inflammation of the endocardium. Or we have rheumatic fever, which is and rheumatic heart disease, which is not infectious by itself, but as a cross reaction to the group A streptococcal infection. The immunity system make antibodies which attack the heart valve and attack the skin and the basal ganglia and causing the complication of rheumatic fever. Myocarditis, pericarditis due to most likely bacterial or viral or fungal. Genetic, the most common is cardiomyopathy. As we know, hypertrophic cardiomyopathy, most of it is inherited, and also part of dilated cardiomyopathy. Immune-mediated myocarditis, pericarditis, like SLE. This problem causing arrhythmia. Dr. Ofa already talked about the arrhythmias, either bradyarrhythmia or tachyarrhythmia. Tumors, either primary or secondary. And as we know, the most common primary tumor or children, the one rhabdomyoma, which is associated with tuberous sclerosis. Others like Kawasaki disease. Kawasaki disease, although it is not common, but it is a favorite exam topic. As we know, it is an inflammatory disease of unknown etiology, causing acute diffuse vasculitis of the medium-sized vessels, mainly the coronary artery. This is our issue, affecting the coronary artery, causing coronary aneurysm and coronary stenosis, coronary thrombosis, and leading to ischemia and myocardial infarction. Kawasaki disease is the most common cause of acquired heart disease in developed countries. But in developing country, like in Sudan, the most common is rheumatic fever. More common in Japanese population and higher in males than females. Typical age is 6 months to 5 years. Less than that or more than 5 years, this is called atypical. And this is the one who discovered this disease in Japanese children, Tomisako Kawasaki. He is allergist, Japanese allergist. Cardiac involvement, as we said, coronary artery. It can cause coronary dilatation or thrombus formation inside this coronaries, or thrombosis, and after that it will heal by fibrosis and leading to stenosis and myocardial infarction. Also, it may cause myocarditis and endocarditis in the first stage. Can present with endocarditis or myocarditis before coronary artery involvement, which it will be after 1 or 2 weeks after fever. Other medium-sized arteries, axillary, femoral, iliac, and renal arteries, and not only the coronary artery. It is medium size vasculitis. As we know, Kawasaki disease, we have a criteria. You have to fulfill the criteria. The most constant criteria is the fever. It is fever, and which is for at least 5 days duration, and at least 4 of the following criteria. If less than this, it will be incomplete or atypical. Fever, besides conjunctivitis, which is bilateral non-virulent. Also skin rash, polymorphous skin rash, mucous membrane changes, especially oral. It will be red, dry, and the lips will be cracked. The tongue will be like a strawberry. Extremity changes like palms and soles, they will be erythematous and edematous. Hands and feet also will be edematous. After that, there will be skin peeling, which is late, not in the first. First will be erythema and edema, and then peeling of the skin, especially fingers. Cervical lymphadenopathy, usually unilateral, and it should be more than 1.5 centimeter in diameter. Right. Also, we have mnemonic, which my heart. M for mucosa changes, H hand and extremity changes, I changes, adenopathy, lymphadenopathy, rash, and temperature elevation lasting for more than 5 days. Here, the clinical manifestation of Kawasaki disease timetable, the fever, this is the first one. And this is the one bringing the child to the emergency. He will have fever, persistent fever, more than 5 days. And after that, arthritis. And cardiovascular, the first thing, it is myocarditis or pericarditis. Myocarditis or endocarditis, inflammation of the endocardium, and even valvular lesion, mitral regurgitation, and later on, aneurysm of the coronary arteries. Skin, first it will be erythema, edema, and then discoloration and nail changes lastly. Lips and conjunctiva, also it will be first erythema of both lips and conjunctiva. Cervical lymphadenopathy first, and thrombocytosis. Thrombocytosis, it is not it will be presented maybe after 2 to 3 days, sometimes after the first week of life. So thrombocytosis first, when the child comes first, do baseline. If not, if there is no thrombocytosis, repeat again after 1 week, you will find thrombocytosis. Here, this bilateral conjunctival injection, non-virulent, there is no pus. Strawberry tongue, polymorphous rash, and here we can see erythema and edema of the hands. And lately, you will find this beard, which is characteristic. Differential diagnosis of Kawasaki, scarlet fever, Epstein-Barr virus infection, adenovirus infection, SSS syndrome, staphylococcal scalded skin syndrome, drug reaction Steven-Johnson syndrome. As we said, that one, the criteria, if fulfill all criteria, this is typical or complete Kawasaki. If what is atypical or incomplete Kawasaki, these are cases of Kawasaki disease that do not fulfill the diagnostic criteria. You will find fever and 2 to 3 of the other, or children more than 5 years. Like children with fever greater than 5 days, 2 or 3 classic symptoms, and then you have to have supporting laboratory abnormalities or echo evidence. If you have echo evidence of coronary involvement, this is supporting the, it should be treated as Kawasaki. Lab abnormality in Kawasaki, first you will have elevated ESR and CRP. CBC, you have to have neutropenia or leukocytosis, non-specific anemia, thrombocytosis. It is a marker of Kawasaki disease, not seen until sometimes the second week of disease, and not common in the first week. Elevated liver enzyme, AST, high ALT, high AST, low serum albumin level, sterile biuria, aseptic meningitis, and echo should be done as the baseline, and after 2 weeks and after 6 weeks. Because the baseline, you will not find any coronary involvement, but you have to repeat it after 2 weeks, and then repeat after 6 to 8 weeks. Treatment, the gold standard is IVIG, intravenous immunoglobulin, 1 dose, single dose, 2 grams per kg. Sometimes, if the fever persists, you can give a second dose. If the fever persists after 48 hours of the initial dose, but most likely it will respond to the first dose. This is rare not to respond, but sometimes you will have a refractory Kawasaki, and you have to give a high dose aspirin 30 to 100 milligram per kg per day. And once the child afebrile, aspirin should be decreased from the anti-inflammatory to antiplatelet, low dose, 3 to 5 milligram per kg per day. If normal coronary artery, aspirin can be stopped after 6 to 8 weeks. If coronary artery abnormalities, long-term treatment with aspirin as antiplatelet. Other anticoagulation if giant aneurysm of coronary artery. If the aneurysm giant, more than 8 millimeter, you can give other anticoagulation like Plavix or even warfarin if it is giant aneurysm. If the child not respond to 2 doses of IVIG and high dose aspirin, sometimes you have to think of steroid. You have to give pulse methylprednisolone. And even sometimes we are going to the immunomodulator like the infliximab. And sometimes if it is very giant and the child have ischemia, we can have coronary intervention by cath or surgery. And this is aneurysm, this one saccular, and this one fusiform. Sometimes it is ectasia, all the coronary artery is dilated, all. Here, this is fusiform of the left anterior descending artery. This is a cath. Cath is mandatory even for a diagnosis of coronary aneurysm and for treatment if coronary artery stenosis or there is thrombosis, and also for follow-up if the patient has giant aneurysm. Rheumatic fever, I'm sure, mashallah, in Sudan, Prof. Sulafa is there, and she is a well-known figure in rheumatic fever. All of you, you know, much more on rheumatic fever. It is the most common cause of acquired heart disease in developing country. 150 in 100,000 in developing country, but it is only 1 in 100,000 in developed country because they have well-established primary care service. They are treating the pharyngitis and skin infection. Rheumatic heart disease is inflammatory change to the cardiac valve and the myocardium. It is the rheumatic fever precipitated by group A streptococcal pharyngitis. To A streptococcal pharyngitis, the body will cross-react and will form antigen antibody complex, which leading to changes in the heart valve. T cell and B cell lymphocyte produce antibody against some streptococcal antigen that cross-react with the antigen on myocyte or cardiac valve tissue. Here we can see if there is environmental factor like crowding, and the host is susceptible to be having rheumatic fever, and there is priming of immune response due to there is priming of immune response due to repeated group A streptococcal infection. The child will have first episode of acute rheumatic fever. So the child, if not treated, will have recurrent episode of rheumatic fever, and this one will lead to repeated attacking of the heart valve and leading to rheumatic heart disease, mainly affecting the left heart valve, the mitral valve and the aortic valve, causing mitral regurg, aortic regurg, and lately this one will heal by fibrosis, sometimes leading to mitral stenosis and aortic stenosis. For the diagnosis of rheumatic fever, till now we are following revised Jones criteria, which has major and minor criteria. Major criteria: carditis, 50%, polyarthritis in 70%, chorea in about 10%, erythema marginatum in 2%, subcutaneous nodule in about 1%. Minor criteria: arthralgia, fever, raised CRP and ESR, and prolonged PR interval on ECG. Regarding diagnosis, we have to have 2 major or 1 major, 2 minor, plus evidence. There should be evidence of antecedent group A streptococcal infection, like positive throat culture or rapid antigen test, or raised or rising streptococcal antigen titer, rising ASO titer, or even scarlet fever. If the child has scarlet fever, some people think it is an evidence of group A streptococcal infection. As we said, 2 major or 1 major and 2 minor, plus evidence of recurrent group A streptococcal infection. There are exceptions if the child has chorea, because chorea, the cross reaction will occur sometimes after 6 months. You will have affection of the basal ganglia, and the child will have rheumatic chorea or Sydenham chorea. Or sometimes if the child has indolent carditis or subclinical or hidden carditis, in this time, we don't require evidence of antecedent group A streptococcal infection, because the infection happened a long time ago. And this ASO titer, it will be high for the first 2 months of life only. This is the exception: if the child has recurrent episode, he will require only 1 major or several minor manifestations plus evidence of group A streptococcal infection. Arthritis is the most common presentations, up to 75%. They are migratory, asymmetrical, and polyarthritis of large joint, typically extremely painful, and highly responsive to salicylate therapy within 3 days. Monoarthritis if history of early use of non-steroid. Premature abortion, the polyarthritis manifestation, the use of early non-steroidal anti-inflammatory. Carditis, 50%, most likely valvulitis. As we said, mitral valve, the commonest, then mitral valve plus aortic valve, then lastly aortic valve. Early disease lead to valvar regurg. First, the child will have valvar regurg. Regarding the mitral, there will be affection of the subvalvar apparatus. The cord tendon will be either elongated or ruptured. Prolonged or recurrent attack lead to stenosis. Yani if first have mitral regurg, then we'll have mitral regurg and stenosis, or what is called double mitral. Pericarditis and myocarditis may occur. It is the pancreatitis actually. Sydenham chorea in 10%. It is a jerky, uncoordinated movement, especially of the hands and feet, tongue and face. This appears during sleep and exacerbated by anxiety. More common in adolescent female. Occur after prolonged latent period following group A streptococcal infection. 6 weeks to 3 years following group A streptococcal infection. Erythema marginatum, rare and difficult to detect, especially in dark skinned patients. Sometimes it will be precipitated by fever, or if you want, you can provide a hot bath to the child. It will appear. It is a circular pattern of bright pink macule or papule that blanch under pressure. It is blanchable. If you press, it will be white. If you remove your finger, it will be pink. It's common in the trunk and proximal extremity, almost never on the face, not itchy or painful. It is painless. Subcutaneous nodule, it is very rare, highly specific manifestation of acute rheumatic fever. It is a round, firm, mobile, and painless nodule in the extensor surface appear 1 to 2 weeks after one set of other symptoms. Last 1 to 2 weeks, rarely more than 1 month. Strongly associated with carditis in the extensor surface. Treatment of rheumatic fever. First, you have to give 10 days of antibiotic to eradicate the residual group A streptococcal bacteria, and you have to put the child on anti-inflammatory agent, high dose aspirin, especially if he has arthritis or carditis. Steroids are given for severe carditis. Congestive heart failure therapy is indicated if the child has heart failure. Sydenham chorea treated by haloperidol or even anti-epileptic drug. Secondary prophylaxis, this is very important. Benzazine, penicillin, it can be used also as a primary prophylaxis. And according to the age, intramuscularly every 3 to 4 weeks. 4 weeks or 3 weeks if confirmed recurrent acute rheumatic fever. Second line, if the child is not tolerating benzazine, you can give penicillin V. If allergic to penicillin, you can give erythromycin. Duration of secondary prophylaxis, if acute rheumatic fever with no or mild carditis, minimum of 10 years after most recent episode of acute rheumatic fever, or until 21 years of age, whichever is longer. يعني الفيرست one هل هو 10 years من الفيرست اتاك ولا التشايلد يبقى عمره 21. الاول اللي بيصل يعني نمشي عليه، سواء كان 10 سنين من الفيرست اتاك او الطفل يبقى عمره 21 سنه. Acute rheumatic fever with moderate carditis, minimum of 10 years after most recent episode of rheumatic fever, or until 30 years of age, whichever is longer. أما إذا كان عنده acute rheumatic fever with severe carditis, minimum of 10 years after most recent episode, or 30 years. And nowadays they are talking about lifelong prophylaxis. And if he has severe carditis, he needs lifelong prophylaxis. This ECG of 9-year-old girl with fever and arthritis. If you have ECG, and you have to look for the PR interval. Here, the PR interval is prolonged. It is more than 208 millisecond. So this is a minor criteria. Prolonged PR interval is minor criteria of Jones criteria. The third acquired heart lesion is infective endocarditis. Is infection of the endocardial lining of the heart or cardiac vessels. If infection of the endocardial lining of the heart, it is called endocarditis. If endocardial lining of the cardiac vessel, it is called endarteritis. Rarely, but with high mortality. It is a rare disease, the infective endocarditis, but the mortality is very high if not treated well. Usually affect abnormal cardiac structure, but it can occur in normal cardiac structure. The abnormal cardiac structure like valvular heart disease or septal defect or presence of foreign material such as mechanical valve or patch material after surgical repair. Etiology, most common is gram-positive bacteria, more than 90% of bacterial cause. Like streptococcal viridis is the most common infectious agent, or staph, especially in polycystic valve. Enterococci, less common in pediatric age group, common in adult. Gram-negative bacteria, less than 10% of bacteria case, like the HASIC group, اللي هي هيموفيلوس وأكتينوباسيلس وكارديوبكتيريوم وإيكينيلا and كينجيلا. ده الهاسيك جروب. Fungal, which is uncommon, but it can occur in neonate and the immunocompromised patient, or the patient having prolonged antibiotic. 10% of infective endocarditis case organism cannot be identified. Sometimes you have to look for the fastidious organism, like Brucella or Q fever. They can cause infective endocarditis, especially if the child has surgery and foreign material like homograft or heart valve can be affected by Q fever.
Bashir, 5 minutes, yeah, Bashir.
Okay, inshallah 5 minutes I will conclude.
Yeah, because there is a lot of question waiting for you.
Clinical feature, general fever, very high fever, even sometimes if you will investigate the normal things, chest X-ray, all the things will be negative. Non-specific manifestation, myalgia, arthralgia, headache, and general malaise. Cardiac, you will have new onset or worsening of heart murmur or valve regurg, congestive heart failure, or even heart block. Clinical feature, extracardiac, like septic embolism. CNS sometimes can lead to infarction or brain abscess, renal, proteinuria, hematuria, and biuria. We'll have renal affection. Stigmata of subacute bacterial endocarditis, genuine lesion, this one, non-tender flat lesion on the palms or sole. Genuine lesion, they are non-tender flat erythematous lesion on the palms and sole. Osselar node, they are tender raised nodule on the finger and toes. These are the osselar node. Rose spot, they are exudative lesion of the retina. You will find this by fundoscopy, and it has rose spot. Splinter hemorrhage, they are non-blanching, linear under the nail. These are the splinter hemorrhage. And you will have, sometimes you will have splenomegaly. For diagnosing of infective endocarditis, we have Duke criteria, which has major and minor. The major, 2, either positive serial blood culture for infective endocarditis, typical organism like strep viridans or staph, or microorganism consistent with infective endocarditis. You will have two or more positive culture of blood sample drawn more than 12 hours apart, or three culture, separate culture. Also, the second criteria, evidence of endocardial involvement, and this is by echo, most likely positive echo of infective endocarditis. This one, you will have intracardiac vegetation or mass on the valve or the supporting structure, or you will have regurg, valve regurg. If you will find abscess or new partial dehiscence of prosthetic valve. If the child has prosthetic valve and you will have dehiscence, this one supporting, this is a major criteria. The minor criteria, if first one, predisposing heart lesion or heart condition, or if IV drug user, fever, vascular phenomena. This one, the major arterial emboli, septic pulmonary infarct, mycotic aneurysm, intracranial hemorrhage, conjunctival hemorrhage, and genuine lesion. Immunological phenomena like glomerulonephritis, osselar node, rose spot, and rheumatoid factor. Microbiological evidence, but not like the positive criteria. Yani not 3 serial or 2 common organisms. Echo finding not consistent with infective endocarditis. These are the major and the minor criteria. Also, the labs, you have to do blood culture. As we said, 3 blood culture collected over 24-hour period. Echo, vegetation, valvular lesion. CBC will have anemia, ASR and CRP high, positive rheumatoid factor, as we said. Treatment, first you have to give supportive because the child is very ill, and then you have to give antibiotic, broad spectrum first. After taking the culture, start broad spectrum antibiotic, and after that, continue according to the organism sensitivity after the result of the culture. And the duration 4 to 8 weeks, depending on the organism type and resistance. And you have to remove the infected line. Sometimes it may need surgical intervention. SPE prophylaxis only indicated at dental, not urological or skin, and for the high-risk patient. No longer recommended for GI or genitourinary procedure. The regimen, either amoxicillin or ampicillin. Patient allergic to penicillin, we can give cephalexin and clindamycin or azithromycin. These are the people requiring SPE prophylaxis. If the child has procystic cardiac valve, or he have past history or previous history of effective endocarditis, or if he has congenital heart disease, like unrepaired cyanotic congenital heart disease, repaired congenital heart disease with procystic material, repaired congenital heart disease with residual defect, or if the child post-transplant, post-heart transplant with valvulopathy, with valvular lesion. Complication of infective endocarditis, valvular damage, septic embolism to the brain, lung, kidney, GI, and extremity, and even this, if not known and treated properly, can lead to death. Myocarditis, inflammation of the myocardium, either infectious, like viral infection, Coxsackie B virus, adenovirus, parvovirus, other cytomegalovirus, Epstein-Barr virus, and other infection, bacteria, rickettsia, or protozoal infection. Non-infectious cause like rheumatological disease, SLE, rheumatoid arthritis, drug, and toxin. Variable initial presentation. I can present with viral prodrome like fever, URTI, GI symptoms. Family past history also. You have to see a sign of heart failure, like tachycardia, tachypnea, galoprism, and hepatomegaly. Sign of heart failure. Investigation: first chest X-ray, ECG, and echo. Sometimes people are going to endomyocardial biopsy, but nowadays rarely used. MRI now it can be used for diagnosis. Treatment: supportive, like giving inotrope, ventilation and ECMO. The child is critically ill. Anti-congestive heart failure medication, IVIG and steroid, but there is no supporting evidence for benefit. But in spite of that, some people are giving antiviral agents and interferon. Cardiomyopathy, either dilated cardiomyopathy, hypertrophic cardiomyopathy, or restrictive cardiomyopathy, and rare type arrhythmogenic right ventricular cardiomyopathy. Thank you.
Thank you very much, Bashir, for this informative talk and very good elaboration for those acyanotic congenital heart disease and the acquired heart disease. There is many questions in the.
We'll choose 3 questions, Muhammad, because of the time. Choose 3 questions, and we'll have 5 minutes to answer.
Maybe he can shed. Yes, maybe Bashir can shed a light for the still the management of the Kawasaki disease regarding the use of steroid and others medication like infliximab, and also when to use the IVIG, the second dose. Kindly can you shed a light for those, because many people asking the same questions. It means that this is important to them.
Yes. Right. Regarding treatment of Kawasaki, all of us agree if the child fulfills the criteria for Kawasaki disease, we have to start the child on intravenous immunoglobulin, single dose, 2 grams per kg over 8 to 12 hours. And then we will start also on anti-inflammatory high dose aspirin. These are the 2 major medication we are using for all children. Most children within 48 hours or even 24 hours will respond after the first dose of IVIG. If not respond after giving the first dose of IVIG, and also we are starting the high dose anti-inflammatory aspirin, and the fever not subsided, then we can start the child on pulse methylprednisolone. If not responding to 2 doses, no, sorry, not 1 dose of IVIG. Can we start high dose aspirin, IVIG, 48 hours not respond, we'll give another dose. If not respond, we have to start him on pulse methylprednisolone, 50 milligram per kg, pulse or cycle methylprednisolone. Some children even will not respond even to the pulse methylprednisolone. What we will do, we can go to the immune modulator medication like infliximab and Kenra, especially if the child is toxic and not responding to the 2 doses of IVIG, the non-steroid, the steroid. We can go to the immune modulator, and even the cytotoxic drug. Some of the cytotoxic drug can be used also in Kawasaki disease. For the coronary affection, we will do baseline echo first to see the coronary, to measure their size, to search if there is any ectasia, I mean dilatation of all the coronary artery or the aneurysm. But most likely it will not present in the first week of life. Regarding the coronary affection, the child not treated, it is up to 25%. But with the treatment, especially the IVIG, they find there is studies, they found that it will reduce the coronary affection to less than 5%.
Okay, Bashir. Can you also shed a light on the poor prognostic factor for the Kawasaki?
Yeah, regarding the Kawasaki disease, the typical one most likely will respond to the IVIG, the one 6 months to 5 years. If less than 6 months or more than 5 years, this is a very poor indication. Male also, male, they have poor prognosis than female. And also, if there is coronary affection, that means the child, especially if it is giant aneurysm. And also the lab, in the lab, also neutropenia, I think. You can correct me, Muhammad.
Yes.
If there is leukopenia, and I think there is a criteria.
Thank you, Bashir. I think now we are at the time for Salah there.